Welcome everyone to the eMedica MRCGP RCA Essentials webinar. So this is the first time we're running this particular webinar. And the reason we're running this is that, since the RCA came about a year and a bit ago, there've been lots of changes. But very recently, they announced a whole load of changes that will take place from September 2021 onwards. And I think some of those perhaps not everyone's aware of. I just want to make sure everyone's up to date, because those of you that are going to be sitting here, hopefully if you're on this webinar, you're going to be submitting for the RCA in the next 12 months. So this is going to be directly relevant to you, okay? So just before we start, a bit of background for those that haven't met me. My name is Muhibur Rahman. I'm a portfolio GP. I'm the medical director of eMedica and a consultant in medical education. Now, I trained in the old system. I did the old MRCGP. And as part of that, we used to also record videos, but I also did an examination called the summative assessment, right, to submit videos that we recorded on, in those days, VHS tape. But then I was also involved in piloting the CSA back in 2006. I actually sat the very first sitting of the actual CSA in September 2007. I passed with merit after passing every case. I wrote the MPS MRCGP study guide and the soon to be released RCA study guide with the MPS. We've been running CSA courses for over 12 years and RCA preparation courses since the RCA came about. And so far, we've trained over 47,500 delegates in the last 15 years. So we've got a lot of expertise in this area. So what we hope to do by the end of this next hour of talk content, I want you to have a really clear idea about the exam. So we're going to have an overview of it. But importantly, all of the key changes that are going to take place from September onwards, i.e. for the next year or so of the exam, including the new mandatory cases, how it's marked, the current penalties, why people might lose marks, for example, or ultimately be failed automatically, reasons for losing marks and failing, and how you can avoid them. That leads on nicely to the habits of those that don't just pass, but smash it and, score really well, pass by a clear margin, not just by 1 or 2 marks. And finally, we'll look at, how to pass the RCA, some useful resources, what other support courses and resources that we offer. And we'll have a Q&A at the end. So you've been using the chat. Please keep doing that to sort of engage. But because, as I mentioned, there's hundreds of doctors on this, I can't follow the chat unless I ask you something, and I'll have a look at it then. Otherwise, I'm going to be focusing on my teaching material. So if you've got a question that you'd like myself or the team to answer, please wait to the Q&A at the end, because a lot of questions are going to be answered. I've already got 2 whole slides answering some of the most common questions that people ask, so that you don't need to ask them, and then ask your questions at the end. Please don't ask questions up until that point, because if you ask questions that I'm going to answer anyway, it still takes time for me to look at that and say, oh, I've answered that, you see. So just please wait until the end, and we'll have a Q&A at the end, okay? So let's start with an overview. RCA stands for Recorded Consultation Assessment. So it was initially designed as a temporary replacement for the CSA when the pandemic came. So, they cancelled what was due to be the March sitting of the CSA, March last year, when we had lockdown version 1, right? And then there was a period where there was no exam. Then they needed to think of something that could be managed to allow doctors that needed to CCT, that needed to pass this last hurdle to CCT last year. So they came up with this RCA. It was only ever designed to be a temporary exam. So what's going to happen now is that they've already realized that there's some good things about it, but there are some things that cause problems with it. And so it is going to be designed to be running until at least spring 2022. So the last confirmed date for RCA at the moment is the April 2022 submission. And they're already working on a replacement exam, which will take some elements of RCA and some elements of the old CSA. And the plan is, once that's been piloted, that from probably around this time next year, the new exam should kick in, okay? So in terms of the format, first thing is you can only sit this when you're in ST3. You absolutely cannot submit RCA in ST2. There's a maximum of 4 attempts by default. You can see here, I've put brackets +1. In exceptional circumstances, someone that had passed AKT, that their trainer and their program director was happy with their workplace-based assessment, successful ARCPs up to date, all of that, then they could apply for an exceptional 5th attempt. That hardly applies to anyone, all right? So what you're going to do is you're going to submit 13 real-life consultations that have been recorded. Now, they could be audios, so i.e. telephone consults. They could be videos, remote consultations, or they could be videos of face-to-face consultations, i.e. patients you're actually seeing in the practice. One of the biggest changes, and I think one of the best changes that's going to happen from September, up until now, each video could be maximum 10 minutes that they would mark. From September onwards, the first 12 minutes will be assessed. You've got 2 extra minutes, which is great. It gives you additional time to finish off your management, your safety netting, and things like that. Now, the 12 minutes that they will mark and that they will watch the video of doesn't include any time that's used to consent or check their ID. You know, like, for example, you do a video consult or telephone, usually you will check that you've got the right patient, check their name, date of birth, address. None of that counts. Similarly, if you're doing a video, sometimes they're still on mute and you have to say, oh, I'm sorry, I can't hear you, you're on mute. And it takes a minute or two to get all of that sorted out. All of that's excluded, but you've done all of that. And then you say, well, how can I help? Basically, from then, the next 12 continuous minutes, they're going to mark. Then they stop marking. They just won't watch a second over that. Okay. And the recording must be continuous. So you're not allowed to edit anything out of the middle. Let's say the video drops, it freezes, then it reconnects, and they can see that there's something missing. You can't submit that. If you do, you'll automatically get 0 marks for that case. So there's no point submitting it. Okay. Anything that's got bits missing or paused bits or edits, automatically that case is 0 marks. Okay. You submit via the 14Fish RCA platform, which is different to the 14Fish ePortfolio that you're using. Okay. And the cases should have an appropriate level of challenge. We'll talk about that later. And you should have a spread of ages and curriculum areas. And there's some cases that you must submit. And if you don't submit them, there are penalties. We'll talk about those penalties because that's one of the really common reasons for failing. So these are the different curriculum areas. And ideally, you want to have a spread of cases from different areas. I don't submit 13 patients that are all, ENT problems. You want to have a mix of these things. So these are the new mandatory cases. Now, some of these haven't changed, but some of them have changed. So I'll mention what's changed as well so that you're clear. So at least one of your 13 cases must be a child, so 16 years or under. And the actual consultation, the nature of it has to be specific to child health. Okay, i.e. it's no good submitting as your child health case someone who happens to be 15, but they've come to speak to you about eczema. And how you would manage their eczema as a 15-year-old is no different to how you'd manage an adult's eczema. It's not specific to child health, do you see? Whereas, for example, if you had, a mum or a dad calling you about their child who's wetting the bed, who's 4 or 5, see, that's a specific issue to do with childhood. That's a good pediatric type case, do you see? Whereas, an adult might have issues with, wetting the bed, but usually that would be related to a cancer or something like that. The conditions where someone's wetting the bed as a child, it's specific to childhood, isn't it? It's different to how you'd approach that in an adult. At least one's got to be an elderly patient over 65 years old. At least one's got to be a mental health condition where the patient's consultation is actually about mental health. Again, if you had someone who's got depression, but they've come to see you today about their eczema, it's just flared up, it's not impacting their mood or anything, they just wanted to get a bit of steroid cream to deal with the flare up. Their mood is actually, well managed, their mental health is stable. It had nothing to do with the fact that they happen to have an incidental diagnosis of depression. That case wasn't anything to do with mental health. You see, the mental health was incidental. If you submitted that as a mental health case, you wouldn't get marks for it. Okay, the consultation needs to be about their mental health. They've come to talk to you about their depression or about psychotic symptoms or about, maybe changing their medication, or they've had a relapse, or they want to come off medication or want to change medication, but it's specific to do with their mental health condition or its treatment. One's got to be a maternal or reproductive health. Now that's quite broad. It can include a wide range of both male and female reproductive issues, but also a lot of obstetric and gynecological conditions. But it, from September onwards, excludes breast lumps, which previously was included, unless they're associated with the postnatal period. Okay, one's got to be a long-term condition. So someone with an existing diagnosis of a long-term condition may be coming because they've got worsening symptoms or for a review. So that could be like a cancer, any chronic disease, a disability, someone with multiple chronic diseases and multimorbidity. And at least one's got to be an acute problem that's going to either need them to be admitted that day or referred to be seen in hospital within 2 weeks or less. So that could include a suspected cancer, 2-week referral. It could include someone that, you think they might have acute pancreatitis. That's an acute admission, isn't it? It could include someone with a query TIA that you're going to have seen within 24 hours or within 7 days. It could include someone with unstable angina that you need to be seen very quickly. Anything that either needs admission or they've got to be seen within 2 weeks or less, that fulfills this criteria, okay? One of the things that's been taken out one of the mandatory criteria used to be you had to submit 2 cases that needed clinical examination. That's been dropped now. You do not need to submit cases that require clinical examination. Of course, if you're doing a case and a patient needs an examination, you're still going to discuss the examination. If you need to do it, if it's face-to-face, you're going to do that. Keep the recording going, but do the behind the curtain so that you don't actually show anything intimate on the tape, because again, you will get no marks for that case if you did that. That's one of the sanctions, the penalties, okay? But you don't specifically need to submit cases that require clinical examination anymore, all right? So one of the things that when I send you the recording, I'll also send you the teaching slides from today. I'll include here our new updated RCA case selection checklist from 2021 onwards. So ideally, you want no more than 2 from any one curriculum area, but that's not absolutely mandatory. For example, if you have 3 brilliant cases that happen to be musculoskeletal, as long as you've hit all the mandatory, that's okay, you could still submit that. But it's just going to help you make sure, am I getting a good spread? Okay. What's absolutely essential, use it as a checklist. Do not submit unless you've ticked all of these mandatory. So child health, 16 or under, elderly patient, 65 or more, mental health, maternal and reproductive, long-term condition, acute, urgent. If you submit and any of these is missing, you are going to lose marks, and there's a really good chance you're going to fail. Okay. And so that's really, you have control. You have control what you record, you have control what you submit. Just do not submit if you do not have all the mandatories. You're setting yourself up to fail. Okay. In terms of case selection, it's really important to look at submitting cases that are at an adequate level of challenge to show you're ready to be an independently practicing GP, i.e. it requires the skill of a qualified GP. Because if you submit lots of low challenge cases, you're likely to get lots of low scores. Now, challenge can be clinically. There are some clinical conditions that are complex, difficult, and so that could be the challenge in itself. Okay. Challenge could be the patient. It could be, for example, a clinical condition that's straightforward, but maybe the patient is really anxious or they're angry, and you have to deal with sort of, how do you approach an angry patient or a patient who's really, really anxious, and you're going to have to use really good interpersonal communication skills, place it in a really good psychosocial context to be able to manage that. That could bring some challenge. Or it could be the situation. Sometimes they might have multiple things that on their own might be simple, but when you put them together, and on top of that, maybe there's a major change in their home life that's making it difficult for them to actually look after themselves. Maybe the situation could bring challenge. Okay, so examples of low challenge cases that you don't want to submit. And if you just had a simple upper respiratory tract infection and they don't need antibiotics, and you tell them that and they accept it, and they don't get upset, and you don't have to negotiate anything, you see, submitting that is not going to give you enough opportunity to demonstrate all the criteria to get a good score. Again, a simple UTI in someone without complicating factors. Okay, someone that came in for a review appointment for results, and the results were either normal, and you just told them that, or they were a simple new diagnosis that they were already expecting and didn't need any complex management. Someone coming for a repeat of the pill and just a simple pill check, nothing's changed since last time, there are no safeguarding issues, they haven't got any new risks in UK MEC such that you have to maybe think about changing them to a different type of pill, they've not missed any pills, so you don't need to think about emergency contraception, because that's too straightforward. Or a simple medication review. Okay, all of these will be too straightforward, there's no point submitting. Okay. This is the RCA Challenge Grid. I've modified it to make it a little bit easier to understand. So look, you could think about conditions which have high clinical challenge. All right. An example of that is a patient with new onset, severe low mood with active suicidal thoughts. That's really complex to deal with in 10, 12 minutes. You've got 12 minutes now, okay? But that's really difficult to deal with, isn't it, in that time? There's a lot to go through. That's complex clinically, okay, in and of itself. You could have something that's moderate clinical challenge. So maybe, it might be a clinical condition that maybe, is either less common and quite difficult to pick up, or there's additional factors that make it challenging. And you can have things that were clinically really easy. For example, simple low back pain, upper respiratory tract infection, acne. In and of itself, acne is quite low clinical challenge, right? Okay. Then you could have someone with multiple complicating factors. So i.e. they've got complicating factors in their behavior, or in their situation, in their home life, in their work life, psychosocial issues. So you see, if you had something that's high clinical challenge, a complex illness with multiple complicating factors, that's going to be really challenging. You probably have lots of opportunity to display the capabilities, but you're probably not going to be able to get through it all in 12 minutes. These are consultations that often run into 20 minutes, okay? If you've got something where it's high clinical challenge and there's even no complicating factors, just from being high clinical challenge, you could probably still submit that because it's got challenge enough, okay? If it's of moderate clinical challenge, again, even with no complicating factors, you've got some opportunity to display. If it's got some complicating factors, you'll have plenty of opportunity to show that, look, I've got the competencies to be a fully qualified GP. Whereas this is the ones where you're in trouble. If you've got something that's low clinical challenge, simple UTI, upper respiratory tract infection, unless there's lots of complicating factors, or at least some complicating factors, don't submit it, because it's going to be in this red zone where it's no complicating factors and it's low clinical challenge. You're just not, even if you do everything well, there's nothing hard in it to show that you're ready to be a qualified GP. You know, it could have been dealt with appropriately by someone else. It didn't need those competencies. There's just not much opportunity to show that you've got the skills. And so you're probably going to get a low score, even if you don't do anything wrong. So it's no point submitting that, okay? Something else that's really important is a common question I get asked is, you know, can I start recording? The answer is it depends where you are. First thing is, you absolutely can't record anything that you could actually submit until you're in ST3. But even if you're in ST3, doesn't necessarily mean you could start recording and you could use it, okay? You definitely could start recording just for practice. So even in ST2, you know, if you want to record just to get some practice, get some feedback, that's really useful. But to record to actually submit, your recording must be uploaded onto the 14Fish platform within 6 months of the exam results. You've got to record and upload within 6 months of the exam results. So for example, can you see the September 2021 is the next sitting of RCA. 6 months, it's actually 182 days exactly, okay? So the earliest recordings that could be used for that is 29th April 2021, but only if someone was in ST3 at that point. So for example, those of you that have just started ST3 in August, if you're planning to submit in September, you couldn't have recorded things to submit in April, May, June, July, only from once you start in ST3. Just, there are two different criteria. One, you've got to be in ST3 to record. Two, it's got to be within 6 months of the results date of the exam, not the submission date. For example, September, the submission date's end of September, okay? But the results is 28th of October. So it's 6 months from the 28th of October. So to make it easy for you, I've got this, and this slide will be in your handout that will come to you, you know, when I send you the recording in a few days. So a lot of you might be thinking, just let me know in the chat, when are you thinking of submitting? September, November, January, March, April. These are the only sittings left of RCA, okay? There are no other sittings confirmed beyond April 2022. That's the last confirmed sitting. Right, so I can see, you know, quite a few people November, and then quite a lot of people early next year, January or March, okay? There's no submission in February. So just to make it clear, again, if you're submitting in November, but you didn't start in ST3 until August, you can't submit anything that you recorded before that. But if you were, you know, you might be staggered, you might be less than full time, and maybe you started ST3 in June. Well, anything from 17th June, you could submit. Those of you planning for January, although you're in ST3 now, you can't record now to submit. You could record for practice. The earliest recording to submit is the 26th of August. So that's in a couple of weeks' time, okay? Why? Because that will be 182 days before the results date for the January sitting, which is 24th February, right? For March, it's 28th October, you could start recording. And for April, it's 9th December, you could start recording, okay? So in terms of the mark scheme, every case is marked in the same 3 domains: data gathering, management, and interpersonal skills. For each one of these, you will get a grade of either clear pass, pass, fail, or clear fail. And each of these grades is worth a certain number of marks. Each case gets marked by 2 examiners, and they add up your score. If it's at the pass mark or higher, you pass. If it's even 1 mark lower, you fail. It's as simple as that. Separate to this, there are 24 feedback statements, which are formative. They don't determine pass, fail specifically, but all the feedback statements are negative things. They're not things that you want to do. If you learn what they are and learn how to avoid them, it can help you get better recordings, okay? So what do the marks mean in terms of numbers of points and standards? Well, a clear pass is worth 3 marks. What it means is you were absolutely excellent in that domain. It wasn't just at the level of a qualified GP, it was impressive for a qualified GP. You didn't miss anything, basically, okay? A pass is worth 2 marks. It means that what you demonstrated in that domain, in that case, is at least at the minimum standard that's acceptable for a fully qualified GP to practice independently without a supervisor. Remember, when you're qualified, you won't have any supervisors, okay? You won't have any trainers. You're going to be practicing independently, okay? So remember that. A fail is worth 1 mark, and it means that you're below the minimum standard for a fully qualified GP. Now, sometimes the difference between a pass and a fail could be one thing. Remember that these grades are for these domains. So data gathering, management, interpersonal. Data gathering is history examination. Did you ask the right questions, explore the relevant symptoms, risk factors, red flags? Did you think of the right examination? Could you do that examination or explain it, depending on if it was face-to-face or if it was remote or if it was telephone? Sometimes missing one red flag in data gathering could be the difference between a pass and a fail. You see, similarly in management, the difference between pass and a fail could be actually managing it according to the current guidelines and finishing explaining that. Okay, so between pass and a fail, sometimes it can be really small, and a clear fail is worth nothing. It means that you're clearly below the minimum standard, or you did something unsafe in that domain. Okay, so the maximum score you can get from each case, can you see, because there's 3 domains. If you've got clear pass, clear pass, clear pass, data gathering, management, interpersonal, you see the maximum score is 9 from 1 examiner, but each case gets marked by 2 examiners. So the maximum score from 1 case is 18. If you've got 9 from each examiner, you'd get 18. That's the maximum for 1 case. Now, the overall pass mark is variable. They set it for 1 cohort. But so far, in every sitting of the RCA so far, it's either been 143 out of 234 or 144 out of 234, which is the maximum score. So that's, it could be different, but that's as low as it, that's the standard has been, either 143 or 144. Now, let's say the pass mark is 143 for your sitting. If you score 143, that's enough. If you score 142, you fail. Okay? Even 1 mark less, you fail. There's no borderline pass, but you don't need to be above it. So, for example, if 143 is the pass mark, even if you score exactly 143, that's a pass. Okay? Now, let me look at the sanctions, because that's how you get marks, but how do you lose marks? Right, so if you mislabel any of the criteria, the mandatory criteria, then it will be treated the same way as if you just didn't submit a mandatory case. You get 0 marks for that case unless that mandatory criteria is met somewhere. So let me give an example. So when you submit your cases, you submit your 13 cases, as part of your submission on the 14 Fish platform, you need to label each case and you need to say which ones are the mandatory cases for which domain. So let's say you label a case, mental health, and it's a patient, like I described before, who happens to have depression, but came to see you today about their eczema, and the depression had no bearing whatsoever on that case, and you have not submitted any other mental health case. Can you see? You mislabeling that as mental health is treated the same as you not submitting a mental health, because you actually haven't submitted a mental health. You get 0 marks from that case, no matter how good the actual consultation was. You will just get 0 marks. So you're losing 18 marks. For most doctors, losing 18 marks will be the difference between passing and failing, because most people that pass are within sort of 10 to 15 marks of the pass mark. They don't pass by much more than that. People that score 20 plus above the pass mark, they've done really, really well. A lot of people pass by only 1 or 2 marks. Okay, so it's really important that you don't mislabel criteria and that you don't miss criteria. Similarly, if you miss any criteria, you just didn't submit any child health case, automatically going to lose 18 marks because you'll be allocated 0 marks for a case. If you miss 2 or more mandatory criteria, no matter how well you score in the other, you automatically just fail the whole exam. And you will need to resubmit and pay for a new sitting, and you can't use any of your good ones from this submission. You have to start again. Okay. If you submit a case where on the video you've recorded anything being examined that's intimate, and an intimate part of the body is shown. For example, you did a breast examination on a lady, and that's seen on tape. You examined the groin in a male patient, and or someone came with worrying about prostate symptoms, and you examined the genitalia, and that's shown on video. You're going to get 0 marks for that case. Or if you breach the rule about not editing or pausing the recording, so you're not got a continuous recording, it skips a bit, you've edited a bit out in the middle, it jumps suddenly from the patient saying one thing to another thing, it's clear that there's been some pausing, automatically get 0 marks for that case. You've lost 18 marks. So don't do any of these. You do any of these, you're just setting yourself up to fail. Okay. So when the results come out, overall, you either pass or fail. There's nothing else. You can't pass with merit anymore. You can't get a borderline pass. You either pass or you fail. That's it. So total marks, maximum is 234 because every case is marked by 2 examiners. Okay, maximum 9 for 1 case, 13 cases, that's 117 times by 2 examiners, 234. You'll be told the marks needed to pass for your sitting. So far, it's been 143 or 144, okay? You will not get any breakdown of how much you scored for each case, but you will get your total score for each domain. Now, what was your total for data gathering from all cases, your total for management, your total for interpersonal skills, okay? So, data gathering is history examination. Management is getting the diagnosis right, managing according to current guidelines, follow-up, safety netting, and interpersonal is communication and consultation skills, being patient-centered, okay? You'll also get any of the 24 negative feedback statements that apply to any of your cases. You'll be told how many times each one applied. So I'll show you what it looks like. Here's an example of someone that just failed. Pass mark was 144 in their sitting. They got 141. You see, they don't know how much they scored for each individual case, but what they know is that their total for data gathering was 52 out of 78. Okay, their total for management was 45 out of 78. Their total for interpersonal of 44 out of 78. And this is what we see. Commonly, people do worst in management and then interpersonal skill. Data gathering tends to be the best domain for people, okay? And they can see their spread of how many times they were given clear pass, pass, fail, clear fail, and so on, okay? And then there's 24 different feedback statements that look like this. So they'll be told that 5 different times this particular feedback statement was applicable, that they didn't develop rapport or show awareness of the patient's agenda, beliefs, or preferences. 5 different times, poor active listening skills and being formulaic. 4 different times, they didn't develop a management plan that reflected current best practice. 4 different times, they didn't show good awareness of risk management. 3 different times, they didn't use psychosocial context appropriately. 3 different times, their language or explanations weren't clear or understandable to them. Do you see? So you get a breakdown of this. I'm just showing you some of it. They might be told some were twice, some applied only once, and so on. But there's 24 different negative statements. Okay. So in terms of the mark scheme, what the examiner is looking for is a complete package. A good way to look at this is GP finals. They're looking for someone who's ready to not be a trainee anymore and to be able to practice safely without any supervisor. So it needs to be a high standard, okay? So they're looking for everything. It's not just one skill. And it's really important to understand this is not just a simple communication skills exam. Communication is only 1/3 of the marks. 2/3 of the marks are clinical. So you've got to have really good diagnostic acumen. You've got to be able to take really good histories, not waste time asking irrelevant questions, but equally know how to ask the right questions in a concise, structured, focused way. Otherwise, you're not going to get through everything in 12 minutes because your 12 minutes isn't just for your history. It's for your history, examination, diagnosis, management, follow-up, safety netting. Get them out the door, the whole thing, do you see? So you've got to know what questions to ask, how to narrow down your differential, ask the relevant risks, relevant symptoms, relevant history, relevant red flags, excluding rare but serious things, relevant examinations, all of that's important. You've got to be able to put all of that together and make, work out the right diagnosis. You've got to have a really good knowledge of current guidelines for management, because if you manage it in a way that might still help the patient's symptoms or problem, but doesn't fit the current guidelines, it's a bit out of date, you're still going to get a fail for management, okay? It's not just about helping the patient. They're specifically looking that you're practicing evidence-based medicine and that you're up to date with your current knowledge of guidelines. Practical skills were relevant. In some cases, you may do a physical examination. It might not be an intimate area, so it might be perfectly appropriate to do that examination on camera. And they're going to see how you're doing it properly. For example, if you're looking in someone's ear, that can be on the tape. That's not a problem. Are you holding the otoscope properly? If you examine someone's, hand joints or their shoulder, you can do that. Can you do it properly? Okay. Now, the mark scheme has got some similarities to the CSA, but it's not the same. First of all, CSA, each case had one specific mark scheme because the cases were written by examiners and played by simulators. Of course, you could be submitting anything. These are real life patients. They can't have fixed specific mark scheme. It's a lot more generic. What they do is look for specific good habits in data gathering, in management, in interpersonal. And then one of the things to recognize that there isn't that standardization in the same way that you can do in the CSA with simulators and its examiners, and we can control the environment. That's one of the reasons why each case is double marked. Okay. So why do people fail RCA? Now, we've been teaching for CSA for more than a decade, and actually we analyzed over 100,000 cases worth of data from the Royal College. Okay, we're the first people to do it. And they published a study in the BJGP looking at why did doctors fail CSA. We've been carrying that on and looking at analyzing, because we help a lot of people who are, resitting, who failed RCA. They're going to come to us to help them get through. I get them to fill in a detailed questionnaire to look at their feedback, to understand and help them interpret it, because often they haven't seen some of these things. Okay, and this is what we've seen are common themes. So number one, sitting it too early. Some doctors, as soon as they get into ST3, they think, you know what, I want to sit the very, very first sitting. And it might be that they've moved to a new practice in ST3 and they're getting used to a new computer system, and they're maybe still struggling on 15-minute appointments, never mind being able to cope with 12. And so they just rush and then they stress themselves out. No one's ever going to ask you when you sat the RCA. Remember, the standard isn't, is this good for a registrar who's still got 6 months left or 9 months left or 11 months left? The standard is, if you're a fully qualified GP and you're the only doctor in the building, would I be happy that you're safe and that you're a good communicator and that you're up to date with your knowledge? Okay. You're much more likely to be practicing at that level further on in ST3 than early on in ST3. So don't rush, because I've seen doctors that fail by a few marks because they rushed. Often it knocks their confidence, because these are real life patients they're seeing. So then they start doubting themselves in their real life consultations. And then often the second time, they either don't improve much at all, or actually I've seen some candidates, they get worse the second time. And then it takes a lot of rebuilding how they consult and building that confidence and building that knowledge. And then they manage to eventually improve. Whereas if that same doctor who was nearly at the standard, if they delayed it by a couple of months and submitted a submission or 2 submissions later, had more time to consolidate their knowledge, to get comfortable in their own consultation style, and also to managing in 12 minutes, they probably would have passed with flying colors. So don't rush, okay? Because the earlier you sit it, or look at it the other way, if you wait until you're ready, you're going to be better at time management, you're going to be more experienced, you will have seen more GP things, you're going to be more confident at not needing a supervisor to review all your cases, or as many of your cases. Number 2, poor history taking. So sometimes examiners will be, deducting marks because in the history, sometimes people will ask questions that's a bit disorganized. They jump all over the place. They're asking about an important symptom, then they suddenly jump to social history. Then they ask about one red flag, but don't ask the other 3 red flags relevant to that condition. They suddenly jump to ideas, concerns, and expectations. And it's a little bit all over the place. Sometimes they'll ask vague questions. If you keep asking, is there anything else? Is there anything else you want to tell me? Often patients, they don't know what you're on about. They don't know what you're looking for. If you don't ask some specific closed questions, you're not going to work out what it is in time. Often they miss red flags. And so, if you miss a red flag, it's not safe. They have to give you a fail for data gathering. Okay. And sometimes doctors will lose marks because they spend too long on their history, because they repeat questions. They weren't listening carefully the first time, or they keep asking, is it okay if I ask you a question about this? Is it okay if I ask you a question about that? Unless you're asking something embarrassing or unexpected, where then it can be helpful to signpost, there's no benefit. They only waste time to keep asking, can I ask you about your pain? Can I ask you about this? Number 3, poor management. So sometimes, in the 12 minutes that's marked, if you just don't finish your management, they're not going to be able to give you marks for it. If you're managing it and you're not aware that the guidelines change and what you propose is out of date, you're going to lose marks for it. And again, if you didn't include safety netting because you either forgot or you ran out of time, hopefully with 12 minutes rather than 10, you'll have more time to get there. But that's common. Number 4, not demonstrating the criteria. It's not enough for you to know it. The examiner cannot read your mind. They can't see your entry on the clinical system on EMIS or System 1 or whatever system you're using. So it's important that you're clear. I'll give you an example. You got a patient with symptoms that fit a TIA, and they had those symptoms yesterday. Neurology is completely normal now, and you've explained that. So according to the current guidelines, they should be seen within 24 hours because their symptoms were within the last 7 days. Okay. If you say to the patient, because you've had these symptoms yesterday, thankfully, there's nothing that I can see today, my examination's all normal. It's great that you don't have any weakness. Your speech is back to normal. So you don't need to go into hospital right now, but it is important that you get seen by tomorrow. See, that's fine. Whereas if someone said, it's important that you get seen urgently, and I'm going to refer you to be seen in hospital urgently. See, urgent's really vague because a 2-week referral is urgent, but 2 weeks isn't safe for someone who's had a query TIA yesterday. Equally, 7 days, which is the right management if someone had symptoms more than 7 days ago rather than yesterday, that's also urgent. But how does the examiner know you mean by tomorrow if you've not said by tomorrow? They can't see the entry. Of course, you are actually going to refer them to be seen by tomorrow. That's going to be your entry in EMIS, but they can't read that. Do you see? So you've got to be clear, right? Formulate consulting. So some doctors, because they're not comfortable in their own consultation style, often some doctors have learned a really long checklist, and it actually might be based on a really good consultation model, but because it's not natural to them, they've not practiced it to make it natural to them. They are following a very rigid tick box mentality. Do this, then this, then this, then this. And in doing that, sometimes it looks like they're not paying attention to what the patient's saying. They miss important cues. I'll give you an example. Someone's got in their checklist, find out about work, find out about home, find out what they're worried about, find out what they want. So they say, oh, who's at home with you? Oh, my wife and 2 kids. Okay, and what do you do for work? And what's going on there? Oh, you know what? I work as a lorry driver, and actually that's one of the reasons I've come today. I'm really worried that if I have to go onto insulin, my boss has told me that, I won't be able to drive the lorry. Right, okay, I've done that. Let me ask him about work next. Right, what do you do for a job? See, that patient just told you about their job in telling you what they're worried about. Or if someone asked them, what are you worried about? I just told you I'm worried about losing my job because if I have to go into insulin. Actually, it shows that you weren't paying attention because you're just going through a list. Also, I see some people have really long checklists, like 15-point checklists. In 12 minutes, if you're thinking about 15 different things, because you're always thinking, what do I need to tick off next? Often you miss an important cue, which could be verbal or non-verbal. You miss something important but subtle that the patient said. And then they might feel like you're not listening or paying attention. And that can be exacerbated when you are consulting remotely. When it's through a video and there's a bit of a delay, or it's telephone and you can't see it and only hear. Okay, so that's really important. Number 6, poor case selection. So either poor quality cases where, they've actually missed things, they're not great, but they've submitted them because they didn't record enough. Low challenge cases, so they get low marks, or missing any of the mandatory cases, because you automatically are going to lose 18 marks for missing 1. Miss 2, you automatically fail, regardless of how good your cases are. Some additional issues specific to the RCA. Time management is really important. Look, 12 minutes is better than 10, but it's still tough, and especially so early on in ST3. This is why you shouldn't rush. And it's different when we had CSA. It's simulators. They had a script. If you gave the right cue, they would give you a very specific thing. Sometimes with patients, they go off on a tangent, don't they? Okay. Sometimes they can be very vague. So you've got to be really good at asking concise, specific follow-up questions so you can actually get the history that you need. Having a poor case mix, missing mandatory cases. Sometimes, even if you know what they are, it can be hard. It can be time-consuming to get hold of them. I'll give you an example. If you're in a practice with both male and female GPs, and you happen to be a male GP, you might find a lot of the maternal and female reproductive issues that those patients often prefer to go and see a female GP about those conditions, especially if you've got a GP who's got a special interest in women's health. Often they will see a lot more of that. Okay. Remember, you can also use male reproductive. So, bear that in mind, and you might see, but just, bear that in mind that sometimes it can just take some time. Level of challenge, you've got to submit, but sometimes you don't get things come through the door that are of the right challenge for ages. And so you just got to be patient. You've got to keep going. Getting consent. Some patients don't want to be recorded. Some patients, they'll want to be recorded if they know it's something straightforward. If it's something that would make a really good case in terms of challenge, it might be a sensitive issue, and therefore they don't want it on tape. And so, that can be a challenge. So again, it can take time. And timescales, it might be that you would really like to get it done by September, but you just haven't got enough. It's important that you delay rather than submitting a substandard submission. Okay, submitting videos aren't good. Finally, recording issues. Sometimes tech fails. Your system crashes, the internet drops, so the recording's got a bit missing from it. Sometimes the quality on a telephone recording isn't great because of something at their line. They haven't got a good connection and it keeps dropping out, for example. Things like that, right? All of these takes a bit of time to get used to the system for the different types of recording and get good quality recordings out there. So if we look at why people have failed, let's look at the opposite. What are the things that I've seen are common in people that don't just pass, but pass really well? They pass by 15 or more above the pass mark, a solid pass. Okay, these are the 6 things that I've seen are really common, and in a way they relate. They're almost the opposite of the things that we see in people that fail. Number 1, they seek feedback on their own consulting early on, and they have insight that they need to improve, and they're willing to take that feedback and willing to work hard and make changes. No matter how good you are, if you seek to be better, that's really, really important. Where there are some people that even when trainers try to give them feedback, they get very defensive and they don't want to listen. They externalize, and often they don't just fail, they end up failing multiple times, because even when they fail, they just blame the exam and they're not willing to look at what can I change to improve. And there are lots of problems with the exam. It's not perfect, okay? But within the constraints of what there is, if you want to pass, you've got to look at how can I improve. Number two, they develop good consulting habits in real life. Remember, RCA are real life patients, real life consultations. So you shouldn't be faking things for the exam and for your videos. You should be consulting at a high level all the time, and then just record some of your best ones and submit those. You're going to be fine. So you want to develop actual good consulting habits. All the things that we teach at our main RCA course, where we actually have practice with simulators, they're the same things I do, and I will be doing when I'm in clinic again. Okay, they're skills that I've developed over 20 years of clinical practice, but the things I'm doing in real life. People that do really well, they're really up to date with their knowledge base. They up to date with their guidelines. They have done a lot of reading, the book work. They understand that if you know your stuff, if you're running short of time, look, I absolutely can't miss these red flags because it would be a fail, because it'd be unsafe. So although I'd like to know ABC as well, it's not essential. I've got enough to work out. It's likely to be this, but ask these 4 things. I can exclude these rare but serious things that would allow me to move on to management and get it done. Okay. Whereas someone that doesn't do the book work, often they will lose marks in management because they don't know that the guideline has changed and what they're practicing is actually out of date. And they're actually doing that in real life. Number 4, they're great communicators. Being a good communicator is a really important part of being a good GP. So they explain things clearly, concisely, confidently. They take on board the patient's perspectives. They're person-centered. They think about the psychosocial context. They involve the patient in decision-making where appropriate. They plan ahead and they start early. As I mentioned, although you can't submit anything that you record from ST2, people that do really well often, towards the end of ST2, they already start forming a study group and start doing some of the reading and practice in some cases just amongst themselves. So that once they're in ST3, if they want to submit it early, they can hit the ground running. They've already got a good knowledge base. They've already practiced. They're comfortable in their own skin in terms of their own consultation style. Okay. And then they plan, okay, this is the date that I want to submit for, right? So this is the date that I can start recording. From that day, they start recording as many as they can. Number 6, they record more than 100 cases. And they have really good quality control, i.e. they're ruthless and brutal. Any that are even borderline, they just delete them. So they're not tempted to submit things that are not quite at the standard. Whereas someone that's only recorded 40, do you see, to get 13 out of 40 that are good is going to be tough. And so what happens is, 4 or 5 are not brilliant, but you submit them anyway, and then you might fail by 1 or 2. Whereas someone that's recorded 120, can you see, they're going to get rid of 100 and something of them. They're going to pick the best of the best of the best of them. They're going to be ones that pass clearly. So what happens if someone does fail? Because unfortunately, some doctors won't pass first time. They will need more than 1 attempt. It's really important that you go through with your trainer or get someone to analyze your feedback that understands it so that they can help you identify your weaknesses and that you actively work on improving them. You must seek extra support, additional training. Try to get more observed consultations. Try to get feedback that's specific, not generic feedback, individual to you. You might just need longer to get a good selection. Sometimes people just knew that because they didn't allow enough time, they rushed their submission, and that's why they didn't actually do as well as they wanted to. It's really important to remember, though, you do need a whole new submission. You can't reuse any that you submit. Let's say you submitted 13 and then you failed and you realized, you know what, I know 10 of them were brilliant. Maybe these 3 I wasn't sure of. You couldn't reuse those 10. All of those will be deleted. You have to start again. On top of that, there might be some that you've recorded but haven't submitted. You could use those, but some of them might have timed out, because now, remember, when you can record is for the next submission. Okay, so bear that in mind too. So how are you going to prepare for RCA? The first thing, get comfortable with about 12-minute consults. So for example, you might still be on 15-minute slots because it still takes a minute for them to sit down and for you to do all of your checks and so on. Or if you're connecting on the phone or the video, that minute or so at the beginning where you're checking the name, date of birth, all of that, that doesn't count. But the next 12 minutes, right? So, if you're on 15-minute consults and you actually can get most of it done in about 12, 13 minutes, you're probably ready to, record something that you could submit. Because if it actually takes you 15 minutes of consultation time, the last 3 minutes, which is probably when you're going to do all your management, that's just not going to be marked. They will not look at it for 1 second. They just stop at 12 minutes, okay? So it's worth practicing cases with a timer. So I got this. This is just a kitchen timer from Amazon. It's about £15. You can get cheaper ones. It's a double timer. You get cheaper ones that a single timer, about £10. It's worth having one on your desk. Have it count up. You don't want it count down and beep in the middle of a consultation. Patients are going to get upset, right? But just for you to know that, how long is it taking me? Okay, it can help. Practice cases with a study group. So, there might be some things that you think, I haven't seen, someone with this type of problem for a long time. Let me practice it in advance. That if I get one, I'm going to be able to do it in a slick way. Try to get as much observed consultations as possible early on with feedback. So that could be joint surgeries where you sit in and watch your trainer or other experienced doctors, where you get them to watch you. It might be where, you record some and then ask them to watch it. It might be some role plays that you do in tutorial. Even in out of hours, you could ask one of the senior doctors to observe you and give you some feedback. It's important that you get comfortable in your own consulting style. Okay, there's not only one way to consult, but if you try to be someone who you're not, if you try to consult in a way that you've read in a book, but you've not practiced enough that it feels natural to you, and it looks wooden and robotic and fake, that will really come across to your patients. They will see you're not comfortable, okay? Revise your core knowledge and all the current guidelines so that you actually, this is going to help you for everyday consulting, not just for the exam, that you want to be up to date, don't you? So you're giving the best standard of care to your patients. So you want to be up to date with the current guidelines. A lot of guidelines changed 2020, 2019, 2021. Study groups can help to sort of practice, okay? And then some people might find it helpful to attend a course where they're going to get lots of practice with, professional simulators with detailed individual feedback, okay? So some tips then. First thing, once you get into the zone of starting to record everything. Anyone that consents, record. Even if you're not at ST3, record just to start getting used to seeing yourself on tape and for use for getting feedback and to improve your style. It's all practice. Most people, the recordings that they actually submit, they get in the last couple of weeks. Everything up until then is practice as helping you develop your consultation technique and your style, okay? But those that submit 100 or more, you're gonna have a bigger range to pick from, much more likely to hit all the mandatories as well. Try to watch back as soon as possible and get a second opinion on a selected few, not on all of them. Your trainer's not gonna have time to watch all of them, okay? But you should watch back all of them, okay? So ideally do it the day you recorded, if not at the end of the week. Don't leave it to the end of the month and you've got 30 to look up, because we know when you watch more than about 5 or 6 in a row, you get fed up, you get bored. Then your quality assurance is gonna drop. So what you wanna do is be brutal. Split things into traffic light system, green, amber, red. Green is things that you think, what, this was brilliant. I hit everything. It's a good level of challenge. I can't see any issues with it. I definitely want to submit it. Maybe just run it by your trainer just to see that, they might pick something up that you've missed because they're more experienced. And then, you could submit that. Amber are ones that you think, what, if I don't get other brilliant ones, I might consider this, okay? Again, you're going to want someone to look at that one. Red are ones that already, look, I know I missed something important there, or it wasn't great, that explanation could have been better. Don't even waste your trainer's time asking them to look at these. Just delete it. It's no good. If it's there, you might be tempted at the end to submit something when it's not good enough. Just delete it. And as you get closer and you get more and more green, start deleting ambers that you think are lower down the pile of amber. Delete them too, so that you're being brutal and you're only left with the cream of the crop. Submit the best of you. Get the team involved, in getting patients to consent. If you explain kindly and ask nicely to your team and they understand, your trainer knows, but for example, some of the other practice staff, if they've not had someone go through RCA, they might not understand what this is all about. So, if they do understand that, and the way that someone asks consent to a patient greatly changes how likely they are to say yes, okay? Similarly, case selection, sometimes, you're missing one or two. So one of the things you can do is if you let the other doctors know, look, I need a child health case. If you get one, would you let me know? I'll swap you one of mine, so that they can help you pick things off the list so that you can actually try to get your mandatories. Read up before the case. In a lot of cases nowadays, we have triage, like I know what's going to be my next video call or my next telephone consult, or, I know what's coming. I've talked to my team beforehand, because often patients aren't directly booking, there's a telephone consult beforehand. So if you know that someone's coming to talk about prostate, read up so you know the guidelines. If you know someone's coming to talk about fertility, read up, so that you have got all the guidelines clear in your mind, okay? Remember, you need to show positives and demonstrate all 3 domains in every case: data gathering, management, and interpersonal. So some useful resources. So there's a lot of free resources out there. And then we also have, resources, whether courses, books, cards, videos, things like that you might find helpful. So these are 2 really good websites. The Pennine GP training website, it's got a whole load of resources for CSA and RCA. And then the Bradford VTS website. Both of these have got lots of, sample cases to practice, some information about the exam itself, as well as that, you should read through, spend a couple of days reading in detail the RCA guidance, the official booklet from the Royal College, because that has all the rules and regulations in detail, okay? So what things do we have that could help people and have been helping people get through RCA the last year plus? So we've got our GP 100 case crammer videos. So this is based on a recording of a full day course that we ran in the past, where we discuss 100 different case scenarios it's just over 8.5 hours of video. It's a long day, okay? So for each one, I discuss what are the key things in data gathering. So, what are the things you absolutely have to ask, how to focus, what are the things you mustn't miss, the red flags, what examination should you think about? Sometimes I demonstrate the examination. What are the current guidelines for management? In terms of interpersonal, I'll demonstrate for certain things how to signpost, how to deal with embarrassing patients, angry patients, uncertainty, how to explain certain things in clear, concise language. And out of the 100 cases, 20 are with a simulator, they're interactive cases. So you'll see the audience is asking them questions. And if you're watching, you can start thinking, what questions would I like to ask? And you see the case unfold, okay? So these are the different cases. And I'll show you what it looks like on the website. So on the website, all the stuff for RCA CSA is here. So the GP 100 case crammer is here, okay? And you can watch this video. It shows you an example of a case, some clips, it shows you some of the videos, it shows you what the booklet looks like. So you get with this a 360-page PDF booklet that has all of the teaching slides, okay? Is a simulator. So there's 100 cases and they're blocks. So, it probably take you half an hour, 40 minutes to watch each one with 5 cases discussed. And you can see the list of cases. They're all different things that you could see in GP. They're all GP focused. So that's our GP 100 case crammer video. And as I said, it comes with a PDF booklet, but some people like to have the paper booklet. We also have a paper booklet available, which is the same as the PDF booklet. It's just printed, rather than you printed it, we printed it for you. That's 360 pages, A4, ring bound, okay? Then we've got our RCA Master Class. Today, this is the essentials. We're just covering the absolute basics, key things you need to know, an overview of the exam, what to expect and how to prepare. But what the RCA Master Class does, it was a half-day course where we actually covered all of this in a lot more detail, but with things that we don't have time for because we've got 4.5 hours nearly. So we cover in a lot more detail how examiners mark. We go through what are the specific marking criteria for data gathering, management, and interpersonal that would demonstrate positives that they're looking for. We have a section where we cover the 24 feedback statements. They're all negative. What are they? What kinds of things might someone do that would lead to it being flagged, and how can you avoid it? I've got a section on consultation and communication skills, how to use the care structure, which I developed over a decade ago, to manage your 10 minutes and adapt it to make it natural to you. How to break bad news effectively, how to explain things clearly, concisely, the consultation toolbox, when to use open questions, when to use closed questions, ideas, concerns, and expectations, how to use them appropriately, things like that. And then we have 6 interactive cases where either I'm doing some cases for the male ones, or Anna's doing some cases for the female ones, and you'll see the doctors that were there doing those cases and how the case evolves. And when we discuss the knowledge base around data gathering, and those 6 interactive cases give you examples of cases that would be suitable to submit. So 2 of them are telephone, 2 of them are remote video, 2 of them are face-to-face, but all at an appropriate level of challenge. And then there's a section on how to prepare effectively. In terms of reading guidelines, some of you that have done AKT with us recently or are doing it know about our case cards, but a lot of people that haven't already used them find them really helpful for RCA. So these are 112 cards, they're numbered, they're up to date. This set was published July 2021, so they're up to date, for example, even with the 2021 AF guidelines, okay? So they cover things like what are the tests you need to do for different things, what are the key features, red flags, management, emergencies, and you can see they're up to date. Like these are the up-to-date notifiable diseases, these are the latest guidelines for this. So those are 2021. Sometimes people find that helpful just to read, to consolidate the knowledge. The booklet, a lot of people actually find this helpful to have it in the room with them if they know they're going to consult and they know a patient's coming with one of the things that's in the 100. They'll have it there just to refer to, so it's there. And then for those that want practice with individual feedback, our flagship RCA preparation course is a full day course, but it's blended learning. So before the course, you get access to these videos, these 4.5 hours nearly of videos. It's the pre-course learning basically. So on the day, it's just practice. We do 25 cases role played with a male and female simulator. You get lots of practice with detailed individual feedback. We've updated it, so you get 12 minutes for your full mock practices. After the course, you get 65 cases and some more videos to watch for feedback. And there's options to include it with bundles with the GP 100. So again, if I just show you the eMedical website, that's right at the top there. Actually, it tends to be filled really quickly. So actually, just this morning, the September course is now full. Okay, we will plan another date either for late September or early October, but as fast as we can put them up, they tend to fill up. Okay, so but there's options to have that with the GP 100 or without. Okay, and one of the things about the course is it's done remotely on Zoom, but we have a male and female simulator, and you'll get feedback from myself and then from another very experienced trainer. So, from the core e-medica team, either Anna or Masuda. Okay, and we've had people that have done really, really well. We help a lot of people who are resitting. There are only 9 doctors. We only take 9 doctors, and for that, there's 4 staff. There's 2 simulators and there's 2 faculty. Okay, to give feedback, and you'll see 25 cases role played throughout the day. So another group that came recently. Okay, so and then we've just launched a new bundle today. Okay, literally this has just been launched today. It's not even available directly on the website. We've got just a specific page for it. It's called the Pass the RCA Bundle. All right, so what this comes with is 12 months access to the RCA Master Class videos, 12 months access to the GP 100 case crammer videos, which is 8.5 hours. The physical, this already comes with the PDF, but we also will include the printed book of the GP 100 case crammer. It will include a set of the clinical case cards. And so all of that, if you bought them separately, would be 566. If you sign up for that today, I'll post a link into the chat. And if you click that link that I've just posted, you'll see, I'll just click it and show you. It takes you to this page. Okay. It automatically apply a discount. So you'll save £117. Okay. So it's £449 instead of £566 for the full bundle. All right. If you don't want all of that bundle, you can find all of these things separately on our website. You can buy them separately. Okay. But you wouldn't get that discount of, when you bundle them. Okay. Essentially, it's like you're getting this, and part of this for free at that price. Okay. Bonus for the first 40. We've got a few copies of these that the MPS who partner with us and sponsor our course have given us to give away. The first 40 that book the new Pass the RCA bundle, we'll send you a copy of this book. You see, this one you can't buy. This is a blue version. Okay, you can see that the version that's available to buy is a green one. Even that isn't available anymore. And it's out of print. Why? Because the 3rd edition, they stopped using the DVD. So it's just a book. Whereas this one, which is a special commission for MPS, as well as consultation skills that will help you for RCA for everyday consulting. It's got a DVD in the back with 13 consultations and critique and feedback being given by experienced trainers. So you can see what kinds of things to do. So we only have 40 copies of this. I can't give any more after the first 40 are gone. I don't have any more. Okay. So the first 40, as well as getting that £117 discount, you'll also get sent a copy of this. Just make sure that the address, that includes UK postage. If you want us to post it outside the UK, it's £20 extra. What I'm going to do before I go through the summary and take your questions, I'm going to cover the most common questions that I get asked, because over the last year, I've had hundreds of people contact me and ask questions. Okay, so I'm just going to go over that again. All right, so that it hopefully preempts some of these questions. So common question, someone asked, does consent have to be on the audio video? No. In fact, it's best practice that it's not. Why? If you're doing it face-to-face, you can use the paper consent form that's on the RCGP website specifically designed for the RCA. And you get the receptionist to ask the patient to sign it before they come in and after they leave to sign that they're still happy. And if they don't sign, you don't use it. If you're doing recordings directly through 14 Fish, and you get a number of free minutes automatically, but when you actually book, you get another 600 odd free minutes. And then if you use more than that, you can buy additional minutes. But if you're using RCA, it's electronic. Whether it's video or telephone, if you're doing it through the RCA platform, it automatically does the consent before and after. And if they say no, it automatically gets rid of it. So you don't have to have consent on the audio or video. Okay. Number 2, do I have to show my whole face without PPE so that people can see my facial expressions and they can hear me clearly? No, it's real life. If you're seeing a patient face-to-face, you need to take precautions for yourself and for them. Wear PPE as you normally would. Okay. The examiners are aware of this, but bear in mind, therefore, to speak clearly, because sometimes it can impact the quality of the audio on the recording. And if the examiner can't hear something, they can't clarify with you, they just might not be able to give you the marks if they don't know what you mean by a certain thing. Number 3, should I pause the recording when I'm examining because I don't want the examination on video? No. If you pause it at any point, you automatically, if you submit that, will get 0 marks for that. Edited videos are not allowed. So if you're examining, take them behind the curtain, keep examining, that's fine, but keep the tape running. If you're examining and it's not something intimate, you can record that examination, okay? It's not that you can't have examination as part of a consultation. It's just anything intimate can't actually be shown on the video. If you're doing it behind the curtain, it's not being shown, it's fine, but you can't pause, you can't edit. If you do, you'll get no marks for that case. Can I use existing COT recordings? It depends. Yes, so if it was done in ST3 and the time limit is met, and you've not already used that as part of workplace-based assessment, and bearing in mind that only the first 12 minutes will be marked, whereas in a COT, 15 minutes is going to be marked, then you could use an existing COT recording. You couldn't use a COT recording that you did in ST2, for example. Okay, you couldn't use a COT recording that's more than 6 months from the results date. If you've got a COT recording that, in the first 12 minutes that they're going to be marking, you haven't hit all the criteria, don't submit that. Can I use a recording that I made at the end of ST2? No. No matter how good it is, only things made in ST3 and within the time limit, and I just remind you of the time limits here, can be submitted. So for example, you're planning to submit in January, anything after 26th August 2022 and during ST3 can be used. If you recorded before 26, like you recorded this week, use it for practice, ask your trainer to watch it. You cannot use it for RCA. FAQs number 2. Can I sit the RCA before the AKT? Yes, but that would mean delaying AKT until ST3 because you can sit AKT in ST2, right? You can't sit RCA until ST3, but some doctors do sit the RCA at the beginning of ST3 and then sit the AKT at the end of ST3. That's okay. There's nothing to say you have to pass one before the other or sit one before the other. You can do it. It's just most people do it the other way, but it is allowed in the rules. Is it okay if I run over a few minutes? Yeah. Just remember, nothing will be marked after the 12 minutes that we talked about. But let's say now in that 12 minutes that's going to be marked, you've actually done all of the key things. And in the last minute or so of recording, you're printing off the prescription and just saying goodbye. You could submit that, it's fine. Because although they're going to stop watching at 12 minutes, nothing that happened after that is important to the marks. So it's okay. Don't feel, because it went over, I absolutely can't use that. You don't have to finish neatly everything in 12 minutes. Most people don't. Sometimes people contact me, they send me a message on email, can I review their recordings and give them feedback? The answer is no. When it first came out, there were some people that offered this as a service, okay? And there wasn't a specific rule in the regulations that didn't allow it. But in the latest version of the regulations, it specifically says the only people that are allowed to review recordings of actual patients that you want to submit for RCA are your trainer and then the examiners. Okay, so within your practice, your trainer can watch it to give you feedback. You can watch it, obviously, and then the examiners. You can't allow your colleagues to watch it. You couldn't pay a service to watch it. If you did that and it was found out, you would be given a fail and disqualified from the examination, an overall fail automatically. Okay, for that submission, and you have to start a new submission. Okay, so that's really, really important. I can't watch your recordings, nor can anyone else apart from your trainer and the examiners. Okay, what I can do is if you come on our, RCA course, the one with simulators, I can give you feedback. We also have one-to-one coaching. Often people who are resitting, they find that helpful. Or people that just want to make sure they clear it first time, find that helpful to come to the course, do lots of cases, get individual feedback so you know what you need to change. Absolutely, you can do that. And in a study group, you could practice case and get feedback from people. That's fine. Can I appeal? So common question, I failed by 1 mark. I failed by 2 mark. I feel that they didn't mark it fairly. Can I appeal to change my score? No. You can appeal, but an appeal is a complete waste of time and money because an appeal can never change the score. That's in the regulation. That's not the purpose of an appeal. Equally, an appeal cannot change the outcome from a fail to a pass. The only thing that an appeal can do is it can get an attempt discounted, i.e. it doesn't count as an attempt. So that was really more important for CSA. So CSA, for example, let's say on the day you were doing your exam, there was building works going next door and you really couldn't hear the patient and it disrupted, the last 3 consultations. You see, that had an impact and you reported it on the day that, look, this was really loud. I couldn't actually hear the patient. And that's why I had to ask some things 3 or 4 times. I ran out of time. I failed my management and I feel that's unfair. They still won't change it from a fail to a pass or change the score. They will say, we won't count that as an attempt. Your next attempt is free. That's all an appeal can do. But for RCA, as you're submitting it and you're in control. Just don't submit ones where it was really noisy and it was an issue. So there's no point appealing. It's a complete waste of time and money. You're just throwing money away. Often people that appeal, because they're hoping it will change and it can't change, they're actually not focusing on improving and preparing for the next time. So, if someone does fail, hopefully it's not going to happen. You're going to be well prepared. You've got a clear idea. You're going to do the work. You're going to pass first time. If it does, contact me, send me your feedback. I'll be happy to look at it. We can help you for next time. Don't waste your time on your appeal. Just focus on preparing. Okay. It's pointless. All right. Okay. Right. Any other questions I will take from the Q&A, but for those that haven't got questions, just to leave you with this summary. Look, the RCA is a comprehensive and a challenging exam. Every case, they're looking at three things: data gathering, diagnosis and management, and effective communication. The standard to pass is that you're ready for independent practice, fully qualified GP, working on your own if you need to. So you must be able to manage your time effectively. Getting honest feedback early on is really helpful. So what do you need to do? Three things, 3 times. Learn your guidelines. Consolidate your knowledge base. Those that know their stuff, knowledge is power when you're doing the actual consultations. It makes you confident in what you're saying. Patient believes you first time, you can move on. You know which questions you need to ask. You can be focused and be a doctor. Practice. Developing your own consultation style and becoming a great consultant is a skill. I've developed my own style over 20 years. The more you practice, the more you're seeing patients, the more comfortable you get in your own consultation style. And then record absolutely everything. Don't worry if you think, this is probably going to be too simple. You don't know. You might have something that seems simple. It might be like, just a UTI is probably simple. If they give consent and record, why? What if while they're talking about it, they give you a cue and then it turns out maybe there's a safeguarding concern or something else comes up? A level of complexity can still come out, okay? A level of complexity can come out that you weren't aware of. You see, whereas if you didn't get consent before, you can't now do it retrospectively. You can't use that now. You have to get consent beforehand. Okay. So just record everything. And, just focus on one case at a time. Don't think, I got to get 30. I did a whole day and I want to get 5 today. I didn't get, just focus on one case. The person in front of you, give them your best. Remember all 3 domains. Listen to what they say, think about it, then decide what you need to ask next, what you need to do next. Don't focus on just the disease. In GP, we don't just treat disease, we treat people, some of whom happen to have disease. So treat the person, look at them as a whole, focus on them. Be caring, be safe, be confident. You're doing all of this, but just then be the best version of yourself and submit those ones. We all have good days and bad days. I'll leave you with this for those that are leaving. We are what we repeatedly do. So excellence is not an act, it's a habit. Become an excellent clinician, become an excellent consultant, become someone with excellent clinical knowledge, and you'll smash it. And then come the result, I get an email from all of you just to let you know I smashed my RCA. So thanks very much, everyone. For anyone that's not got questions, have a great evening. I might see you at the full course, or if not, you might use the bundle or some of our resources. I hope you find it helpful. If not, I hope you found this helpful. And we've got various other videos and things on our YouTube channel. By the way, we've got the National GP Training Conference coming up on the 4th of September. Some of you might be interested to attend that. It's a full day where we'll be having workshops that are GP focused. It's going to help you with the consulting. It'll help you with RCA. It'll help you with becoming a better GP. So this year we've got Dr. Lifina Diamandis, qualified last year. She's going to give tips for new GPs based on first-hand experience in the last year. Dr. Daniel Jackson's a consultant psychiatrist. He's going to do psychiatry for GPs. Which conditions we should admit, which ones we should refer urgently, which ones we should manage in primary care, how to take a good psych history, how to do a mental state examination. Mr. Imran Khan is a consultant ophthalmologist. He's going to do ophthalmology for GPs, eye conditions and how to approach them, how to take a good history, how to examine. Dr. Hamid Khan is both a portfolio GP, a senior lecturer at St. George's, and he works in emergency medicine for the last 8 years. Okay, so he's part-time GP, part-time emergency medicine. So he's going to talk about, but in pediatric emergency. He's going to talk about pediatrics for GP. So again, common peds conditions, how to take a good peds history, how to examine children if you've not done a peds job and aren't familiar, which ones to admit, which ones to worry about, which ones to manage. Now I'm going to do a session on GP career options, partner, salaried, local, and portfolio GP, and I'm going to look at dealing with difficulties in training. So, how to deal with challenging consultations, angry patients, someone wants to complain against you, how do you deal with that, failing exams, and more. Okay, so watch out for that. That's the link for that, live.gptraining.info. I'm going to spend the rest of the time just answering questions. Okay, I will leave details of this on here, and I will post the link for that again. Just a reminder, any questions in the chat are not going to be seen because there's, as I mentioned, 600 plus doctors registered today. I'm only going to address questions in the Q&A that haven't already been answered, okay? And just give me a second, I'm going to have a look at the questions. Some of them are repeat, so, shall we look at that? So someone said, can we submit while on maternity leave? So if you're technically in ST3 and then you go on maternity, you could do, but of course, remember that it's going to be difficult for you to record while you're on maternity. So if what you mean is that you did all of your recordings before you went on and you're technically in ST3, but the actual final picking which ones and the submission happens while on maternity, yes, you could do that. But if you're just on maternity, you're not going to be able to record, are you? Someone said that they're ST2 now, starting ST3 from February 2022. So does that mean that they can only start recording after February 22, not before? Yeah, you can't record anything in ST2 for submission. You can record for practice and to get feedback. You can't submit anything that you record in ST2. And even once you're in ST3, remember, it's got to be within the window, 182 days, so 6 months from the results date for your planned submission, okay? Someone said, is there any minimum cases need to be passed? So it's the minimum score that needs to be passed. You don't pass or fail individual cases. You only pass or fail the exam as a whole based on your total score, okay? Someone said, can you submit all telephone consults? Yeah, you can. If you want to submit all telephone, you could. If you want to submit all video, you could. If you want to submit all face-to-face, you could. If you want to do a mix, it's entirely up to you, okay? Someone's asked, do you recommend taking your course early on or near the submission date? Great question. We normally say a good time to come is at least a few months before you plan to submit. Why? Because you're going to get lots of feedback at the course, but because there's 9 doctors and we do 25 cases, you're also going to see other people doing their cases and them getting feedback. You can learn from that too. So, if you come like a week before or 2 weeks before, you then haven't got any time to make changes from the feedback you're going to get to actually improve your consulting. So, 2-3 months before, maybe 4 months before is a really good time so that you get into good habits early. So for example, people that are coming to our course beginning of September, most of them are planning to submit January, February, because we ran courses in July for people that were planning to submit in September, okay? If when you sign up to the full day course, you get access to this masterclass, that's actually the pre-course learning for that. So you can learn what to expect, how to do well, cover consultation and communication skills and how to structure. So you can do that early and make a start on your recordings, then come to the course to fine tune it. So, if you came, say, a month before or 2 months before, there's still going to be a benefit from it, but to get the full benefit, it would be better to come, 2, 3, maybe 4 months before would be ideal. Okay, that's what I'd recommend. Someone said, is sitting the November RCA a month after the AKT a good idea if I have good recordings? Well, the thing about RCA is, you're seeing patients anyway. So if you get in the habit of recording anyway, and you're in the window, if you've got enough good recordings, then a month's plenty of time to, if you only need a few more, and then to actually assemble which 13 do I want to actually submit, get the trainer to see some of them, do that. That's plenty of time. If you're thinking, oh, can I just start recording after AKT in end of October and then submit in November? I wouldn't think that's a good idea. You're putting a lot of pressure on yourself. But if you already got lots of recordings, yeah, absolutely, you could definitely do it. Someone said, are you able to share the RCA mark sheet scheme? So details of that, of exactly what are some of the things that they're going to be looking for in data gathering, that's covered in detail in this section, module 1 of the RCA Master Class. I don't have time to cover that today. We're already over time. Someone said that, can you guide on ways of recording on 14Fish? So can you do it on your own mobile? So yeah, the best option is to use 14Fish, because then the consent is done, it's automated, it's already in the right format. You can record on, a phone with consent, but then you've got to make sure that you store it in a certain way. You've got to think about data protection. You've got to make sure that you upload it as soon as possible afterwards, because let's say you hadn't uploaded it and then your phone got lost and someone got hold of that, you're looking at huge fines for breach of data confidentiality there, okay? So I wouldn't recommend using your own phone, but it's possible with consent. It's just important that you transfer. The other thing is that it just adds a lot of time. Why? What you'll find is your phone doesn't record in the same format as the 14Fish. So even after you upload it, you then have to process it into a different format, which can take a really long time. And if you're doing hours of someone recording 100 cases, 15 minutes each, that's hours and hours of videos. It would take them days of processing time to get them in the right format. So it's best to go through 14 fish wherever possible. But if not, some people have automatically recording of telephone consultations in their practice. You could use those recordings, again, with consent, but you'd then need to upload that recording and transfer it to the right format, but it's possible. Someone said, what's the best way to record consultation? I recommend the best way is to directly use the app for 14 fish. So whether you do telephone or whether you do remote video, you can do it through 14 fish. And in terms of how to capture the actual thing, use a good quality webcam so you can position it, and details of the technicalities of how to get good recordings, that's actually covered in this session. Again, in module 1, we've got tips for recording, how to get good quality, the right angle, how to get good quality sound, what kind of equipment, that's all covered. Okay. So a few people have said, what if, I'll try and summarize to save time, what if I only wanted some of this, or I've got part of this, or I don't want 12 months? If you don't want the bundle, that automatic discount is just for the bundle. Okay. If you want any other bits of it, you can just buy them separately. So for example, if you just want some of it, the discount only applies to the bundle. Okay. If you want anything else, let's say, you've already got this and you now just want to get this, you could just subscribe to the RCA Master Class. Okay. You see, let's say you don't want 12 months, you just want 3 months. You could just get this for 3 months. Okay. But that bundle is so heavily discounted. It's like you're getting this, and part of this for free, or like sometimes someone might say, I only want this for 3 months or this for 6 months. But if you bought those separately, it actually costs more than this. So just get this, you're better off. Okay. So, if you don't want the bundle, the discount is only for the bundle. For any other bits, you can always top up and get it separately. Okay. I said, what if I get the 12-month bundle? Would I get any updates? So yeah, it's a really good question. For example, these videos were last updated today. Okay. The latest, so whenever guidelines change, like the Royal College changed the exam 4 times since last year. Whenever it changes, I basically record an update or do changes. So like these were updated for the latest set of guidelines in terms of like 12 minutes and, the new mandatory, all of that was updated today. These were last updated last month, so they're up to date as of July 2021. So, we've included a bit about, for example, the fact that the Orbit bleeding risk tool is used now instead of HAS-BLED as the standard tool for looking at someone with AF. You're going to put them on anticoagulant, looking at bleeding risk. So anytime things change, when we update them, as long as your subscription is active, your videos will automatically update because you don't download them, you access them live on the website. You log in and access them. So, you'll automatically get them. The only thing that won't change is things that are printed. You won't automatically get another printed copy. You need to buy a new printed copy if you want something new. Okay. But for example, the PDF version of this, which is included in this, that would automatically get updated. Okay. Okay. Someone's asked another really good question. That let's say you submit for March. You see, the results are going to come out 28th April. By that time, it's too late to submit for April, not to submit for April, but to submit, but also the application. Yeah, that's right. So if you submit in March and you didn't pass, you're not eligible for April. But like this year, what they did, they held a specific limited July submission only for people that were resitting from the March or April submissions. Okay. But for example, it would be too soon anyway to try and submit for the April submission, because remember, you can't use any of the ones that you submitted already. So you're going to need time to look at but some of the other ones you've already recorded, you might be making some of the same mistakes that got you marked down in the submission that failed. So, you're going to want to look at that, have some feedback, and actively start making improvements in your new recording. So it can take a few months. I wouldn't recommend rushing to resubmit. Usually takes a good 2 or 3 months to submit another good submission. Okay, get some feedback. Someone said, can we record in out of hours as well for RCA? Yes, you can, if you have recording equipment there and you have consent. Someone's asked a really good question. What if it's something rarer and you double check the guidelines during the consultation? Would this be okay? Absolutely. I do that in real life. When I'm in clinic, I will have NICE BNF already open as a separate window. Okay. And then I'll often look something up in NICE CKS just to check. Sometimes guidelines have changed and you didn't realize that just a couple of months ago they changed it. So I'll often double check things. And then just like in real life, some things are rarer, so I have Oxford Handbook of General Practice. I'll often look things up or do a quick search. That's absolutely fine. But remember that will take some time. So bear that in mind. But also remember that you're still being marked continuously. So it's important that you communicate. Say to the patient, this is something that's really, really rare. I'm just going to double check the guidelines. I want to make sure that I get this right for you. And then look it up. It's fine. Okay. Or if you just start looking And then they've just asked you a question and they think, what's happening here? The doctor's ignoring me for a while. Do you see that in terms of interpersonal, that might come across as you're not really paying attention to them. Do you see? So, that's absolutely fine. Just like in real life, I look things up all the time. It's very sensible to do that. Someone said, can you link two areas in one case? Yes, good question. So for example, what if you had an elderly patient with a mental health condition and it was about that? Could you submit that and tick two mandatories with one? Yes. Similarly, what if you had a child and they had a mental health condition? And how we treat children with mental health is very different to adults, because for an adult, we might start treatment ourselves in primary care in terms of medication. For a child, you're going to refer. So actually, that's a good example. You could tick two things with one man. You still need to submit 13 separate cases, but you can tick more than one mandatory thing with one case. Okay, you can link it to two things if you want. Again, a few people have asked if they get this bundle, does it include one-to-one feedback intensive session? No, that's a completely separate thing. But if you book this bundle and then you want to come on the full day course with practice, email us and we'll give you a discount because you've already got this. We'll give you a discount. Okay. A few people have asked, how do you set up these recordings? So again, the technical ways of getting a good quality, how to position your camera, position your audio, things like that is covered in this module here. But in terms of how to actually use 14 Fish, things like that, 14 Fish have got great tutorials on that. Just go through those. Someone said, what if someone takes September and fails and they want to sit in November? You can't. You're not eligible for it. The earliest you could resit is January. But realistically, you wouldn't be ready to submit a whole new submission of good quality and make changes to your consulting. It'd be unlikely to be able to do that in time anyway. So it's good that they don't allow it. It would actually, more people would end up failing. Someone's asked, they're planning to sit in September. They're doing lots of recordings already. What do you recommend in the remaining time? If you've already got really good quality recordings, you're happy, your trainer's happy, just keep going. And, be ruthless about, like, if you get even more good ones, you can see some that are fairly good, you can get rid of them and just submit only brilliant ones. That's a fantastic position to be in. Well done. So just keep going. Someone's asked a good question. Is it important to apply at the beginning of the application window because of the possibility of limited spaces? No. As long as you apply within the application window, then they should accept your application. What sometimes happens is sometimes they extend the results date because there were a couple of sittings where more people submitted than they were expecting. So what they did was they just extended the results date because it took longer to mark them all. But it would be unfair of them to, if they've said this is the window, to not let you apply as long as you're within the window. Okay, so don't rush and feel pressured. If when this window's here, if you've got any doubt, if you think you'll be ready for here, leave it out. Go for November. It's much better to go a bit later than a bit early and have more time and have brilliant videos and weed out even more of the ones that are borderline and have fantastic ones. Then again, okay, great. That's the last question. So huge thank you to Masuda and Anna for answering all those questions and helping me. Thank you very much to all of you for giving up part of your evening. I know how pressured it is. I really hope you found it helpful. I hope you've got a much clearer idea about the exam, about how to approach it, but more importantly, about some of these new changes and guidance, because sometimes people don't find these things out until a bit later. For example, sometimes people might start recording and using up their minutes. You can record for practice, that's fine. They might start using up thinking, you know what, I'm in ST3 now, so I'm ready. I want to do it because they thought it was 3 months, or they thought it was 9 months, or they thought it was 6 months from the application date rather than the results date. And so, but unfortunately that they can't be used. So, hopefully you've got a much clearer idea. Also, you might not have known about some of the changes in the mandatory criteria. So again, I hope that that's been helpful to you, and I hope that you've got a much clearer idea. Okay, so thank you very much. And I will be in touch with you in a few days. I'll send you the recording of the main talk session and the slides, these teaching slides. Okay, take us a few days to process all of that. Okay, huge thank you to the whole eMedica team for all of your hard work and support. For all of you preparing, keep pushing, keep going, prepare, and you will succeed. Thank you so much, and I hope to see some of you at the National GP Training Conference. Okay, 4th of September. Thank you so much. Have a great evening.